Hi, I'm Jenny Dyke. Welcome to Aspen Valley Hospital's Medicine in the Mountains. With me today is Dr. Chris Beck. Welcome, Dr. Beck.
Thank you.
Nice to have you today. It's been a while since
Yes,
you've been
indeed.
on the show. Dr. Beck, for those of you that don't know him, that's probably a good thing because he's an anesthesiologist. He's often the last person you see before surgery.
That's right.
Yeah, so, and you've been here a few years now.
8 years.
8 years, yeah.
Yes.
Time flies. Huh.
Yeah. And
All right.
currently the Director of Anesthesia Services.
Director of
at the
Anesthesia
hospital.
Services. You're also the president of the medical staff.
Yes.
And have been now for
4 years.
Yeah.
Yeah.
You got reelected. They'll keep reelecting you.
I'm going to try to avoid that.
Yeah, don't miss the meeting when
Right.
they do the elections,
That's right.
or you're sunk
Yeah.
yet again. But it's nice to have you here today, and we are going to talk about pain management. Obviously, a really important topic in the healthcare field.
Yes, indeed, for a number of different reasons.
Yeah.
And I think people intuitively know that it's important just
Yeah.
because people don't like to be in pain.
Yeah, pain is never good.
Right.
So why don't we start with the physiology behind the pain process?
Okay. So pain is the neural processing of noxious stimuli. And that noxious stimuli could be a burn or stretch or pressure. It can be chemically induced. Inflammation, trauma, all of those things have are noxious stimuli, and they activate nociceptors, which are nerves that detect those types of noxious stimuli. And they're free nerve root endings that then send a signal to the central nervous system and tell you where the pain is and the different types of nerves and where they synapse in the brain will create the different characteristics of pain, whether or not it feels like it's burning or sharp or dull. And the different parts of the body and different tissues and different organs tend to have a predominance of different types of nociceptors. So the skin, and say the hand, is very good at detecting sharp. It's good at detecting pinprick, and it's good at detecting exactly where that pain is. Whereas your stomach or your internal organs aren't very good at telling you exactly where the pain is, and they're not good at detecting sharp, but they are good at detecting stretch and inflammation. So different parts of the body have different types of nociceptors that are geared towards different goals for how you as an organism should respond to that pain.
So it occurs to me then, as you talk about receptors, for instance, in the fingers, probably that's partly a defense mechanism for the body.
Absolutely. So you have pain fibers that are very fast acting and can send a very quick signal. And then there are other pain signals that are sent through slower nerves and have more of an emotional impact and tend to reflect the visceral organs. But with the hand, you want to have a good quick pain reflex to withdraw your hand. And you also want your hand, because your hands are very important for your survival, your hands have a lot of nerve fibers, whereas, say, the center of your back, even though it's also skin and somatosensory as opposed to visceral organs, but the back doesn't have as high a density of nociceptors, whereas the hand has a very high density of nociceptors, so you can identify whether or not it's your pinky or your ring finger. Whereas on your back, you probably can't identify quite as closely exactly where someone was poking you with a pin as you think you can.
Right.
Once under studies.
It's probably why you can get just a tiny little cut on a finger too, and it
Right.
really hurts, where
Yes.
on another part of the body it wouldn't be so bothersome.
Exactly.
And then when you talk about other parts of the body that aren't as sensitive as like the fingers are, is that why we sometimes have referred pain where?
Absolutely. Say if someone's having gallbladder pain, they can feel like it's in their shoulder. That's a very common referred pain. Or someone having a heart attack will feel like they're having pain down their left arm or up to their jaw. And that has to do with where those visceral nociceptors insert themselves and synapse with neurons in the central nervous system, the spinal cord, the thalamus, the somatosensory cortex, the frontal lobes in the brain, where those visceral organs synapse in the central nervous system. When they're extremely stimulated, some of the neurochemical signals spill over to the somatosensory part of the central nervous system, meaning the somatic system, the part of the body that you can identify and tell exactly where it is, not the visceral organs.
Okay.
So the left arm in the central nervous system synapses
Okay.
close to where the heart does.
Yeah.
And the right shoulder synapses, and the shoulder blade synapse close to where the gallbladder signal comes into the spinal cord.
Yeah.
And so referred pain is very common with visceral types of pain.
So you're getting the message. The body is sending a message, and then you have to sort through, okay, where is that pain really coming from?
Right, exactly.
Because it's not necessarily the shoulder.
Yes, and clearly that can be a conundrum for diagnosing people. And someone could think that they are having a rotator cuff injury, but they might actually be having coronary pain.
Right.
So,
they go to the orthopedist when they should have gone to the cardiologist.
And we've all heard of those stories, exactly.
You bet. Right.
Yep.
Okay. Now, is there a mechanism in the body where once pain gets going, if it doesn't get addressed,
absolutely,
that it just gets worse and worse and it kind of builds?
Yeah, definitely there's a phenomenon called wind-up, where pain that at one time was what we would call physiologic pain, it can move into the realm of being pathophysiologic, where the body starts to have abnormal circuits and positive feedback loops of its own neurochemicals and neurotransmitters that then feedback on the nerves themselves and make them hyperexcitable.
Okay.
And so it's called a wind-up phenomenon, and that can lead to chronic pain. And so initially, in the acute pain phase, you can have pain that is physiologic, but it also can become pathophysiologic in that it's so severe that you can't sit still, you can't sleep, you can't think about anything else, you can't function with your activities of daily living. So that's severe acute pain, but severe acute pain can develop into chronic pain after a certain time frame.
Okay. So it seems like the earlier on that you address pain and try and get it under control, probably the better you are, probably even with minor things. I mean, I find that with a headache.
Right.
If I can take something early on, I can kill it. If I don't, it just gets worse and worse and worse.
Right. And there are a few things that I could add on to that perception that you have that I think everyone has intuitively, like you're saying, is that one is that people can cope psychologically with a certain degree of painful stimulus for a certain amount of time. But try doing it for 6 hours or 12 hours or 24 or 30.
Yeah.
And all of a sudden what you could have tolerated for 2 minutes,
right,
it would have been really painful, but try keeping that going for 30 hours and all of a sudden your coping mechanisms aren't keeping up anymore. And even if it's the same degree of painful stimulus, it'll seem much worse. Just like that same degree of painful stimulus will seem much worse at 2 a.m. when you're trying to sleep and your circadian rhythms are saying sleep, versus the same painful stimulus at 9 a.m. when your body's ready to cope and deal with life and solve problems. And then additionally, when we think about surgical pain relief for surgical processes, we can take the idea of getting pain under control to another level, which is where we call it preemptive analgesia. So we start the pain relief process before the pain signals even started. So we give people pain medications in the holding room or even the night before surgery, most often just the morning of surgery though, a pain pill before the surgery's even started.
So by the time they come out of surgery, it's already working.
And it
for
could
them.
be a pain pill, or it could be other types of pain modalities. Specifically, other very good preemptive analgesic techniques are numbing techniques, and those are probably the best. So if you numb up the joint before it gets replaced, say the knee, let's say we numb up the knee before the total joint, we think that there's good evidence that we decrease the rate at which a person develops chronic pain from a total knee replacement. And there's good evidence for this in other surgeries, like gynecologic surgeries. If we numb someone up with an epidural, potentially before a total abdominal hysterectomy, rather than after or never, there's a lower rate at which we see that group of patients develop a chronic pain syndrome.
Right, it makes sense, because then they don't
right.
wake up with severe
Yeah.
pain that just
So,
and get the
yeah,
wind-up thing going.
Exactly. So in the realm of preemptive analgesia and just good pain control, there are enough reasons to give somebody good pain control during the acute phase of the pain without even thinking about the chronic pain part of the whole equation. But nevertheless, the chronic pain part of the equation is still an important and beneficial aspect of preemptive analgesia, numbing techniques, and adequate analgesia throughout the course of a traumatic experience like surgery or other traumatic experiences.
Right, which is very reassuring, actually.
It is.
I would imagine
And
patients love to hear that you're doing things to preempt their pain.
right, and this is a push nationally by the American Society of Anesthesiologists, the Association of Regional Anesthesiologists, pain anesthesiologists. Many surgeons are very in favor of preemptive analgesic techniques or numbing techniques, like the American College of Surgeons, for epidurals, for numbing people, for chest surgeries and abdominal surgeries. However, I would have to say that nationally and internationally, these techniques aren't used as often as the literature might suggest. And I would say that even in the state of Colorado and amongst the practices of anesthesiologists that I have contact with, there's great variability in how well and often these techniques are applied for a given patient population for a number of different reasons, having to do with the anesthesiologist's training experience, the surgeon's preferences, patients' expectations, and how well they're educated about the different techniques and the risks and benefits, because often patients can be wary of an injection technique.
Right.
There are risks with that. Epidurals, people may not feel that comfortable about having someone numbing them in their spinal column.
Right.
And there are definitely risks and benefits, but there are a lot of risks to not doing these things as well.
Right.
We touched upon the chronic pain risk of not getting on top of that pain early, but there are also a lot of risks associated with not dealing with acute pain well in the hospital.
I would imagine that acute and severe pain that could come from a surgical procedure can really affect the patient's well-being to the extent that it could affect their recovery time and their healing. Is that true?
Absolutely. And to the degree that the Joint Commission has decided to call pain the fifth vital sign, and that it's measured objectively on the pain scale of 0 to 10 that a lot of patients are very familiar with if they've been in the hospital. And so it's something that is taken very seriously, because without adequate pain control, people can have excessive stress responses. So a certain amount of stress response is physiologic, to use the terms that I used earlier. And then excessive stress response becomes pathophysiologic. And the release of those endogenous hormones like adrenaline, endogenous cortisones, vasopressin, and antidiuretic hormone, in excessive quantities, those hormones can be very detrimental to a person's healing response. There can be excessive heart rate and blood pressure, which are very objective signs that in a certain patient population will lead to an increased risk of cardiovascular morbidity and mortality. There are issues with healing. With adrenaline, you get vasoconstriction of blood flow to the surgical wound. There can be risks to the wound not healing as well, to the skin not healing in a timely fashion, increased risk of infection. All of these things are very important for healing, and a certain amount of pain is to be expected after any trauma or surgical procedure. But there's a range at which it's physiologic and the pain is actually okay and not detrimental and functional. That pain, just like
people can get through it.
And then there's a stage at which it becomes pathophysiologic, and it really becomes a negative impact on that patient's well-being and healing. And I think analogously, people, as far as thinking of physiologic versus pathophysiologic, I like to think of the analogy of everyone's familiar with a fever from having a cold or in a child.
Sure.
And it's physiologic when it's 102 or 103, you start getting into that 104 and 105 range, and pathophysiologic when someone has a seizure.
Sure. Yeah.
And so that fever functions well for the organism, the child or the animal or the mammal, in a certain
normal
range,
reaction.
but at some point it becomes pathophysiologic, and the organism's response and healing effort starts to become counterproductive. And we see the same thing with the stress response in response to pain.
Yeah. Oh, that's a great analogy, because it really does put it in perspective. Now, why is it that some people seem to have a really high tolerance for pain and some people not so much?
Well, I think
is that a psychological thing, or
there's definitely a psychological component, and I think I'd like to say that I think there are three main factors for why we see a difference in things. First is that it's very difficult to ever compare apples to apples when you're comparing one person's pain to another person's pain. Okay. One person's ACL surgery is never exactly the same as the next person's. No matter how, even if it's the same surgeon, let's say, the other injuries that might be in the knee, meniscus repairs or MCL injuries simultaneously, the type of graft that was used. So sometimes people will think that someone else had a harder time with surgery versus somebody else, but the procedures may not have been the same. Or let's say like two women, one woman needs an epidural for labor and one doesn't. Well, there are so many differences in the laboring process. You can have a functional labor or you could have a dysfunctional labor. One person cannot survive that dysfunctional labor experience comfortably or even in their right mind without some degree of pain relief, whereas someone else might fly through a labor process in 90 minutes.
And it doesn't really mean that person's tougher than that person.
They're just different events.
Yeah,
and
okay, good point.
Then, so number two, I would say is just genetic. So at one end of the spectrum, as an extreme example, there are rare people in the world who have congenital analgesia or congenital insensitivity to pain. They just don't feel pain.
Yeah.
And it's very detrimental to their survival, because pain is very good for knowing not to go too close to the fire.
Right.
So if someone doesn't have, and so people with this congenital condition have been studied, and different individuals have different mutations, genetic mutations, that don't allow their body to process pain. And you can find those genetic mutations at any point along the pain process that you and I discussed at the beginning of the conversation. So that's an extreme. But you can imagine that there's so much we don't know about any of us in terms of what exactly do our genetic pain pathways look like. Genetically, how are they expressed? There could be very minute differences in the nociceptors, in the synapses, in the neurochemicals, in the emotional limbic system response to pain. So many things we don't know. So I think probably the biggest component to this, aside from the perception issue, is just genetic.
Right.
And other differences I think include, just to focus, I think a lot of it is perception. And one person might think, well, I was really tough when I had my my accident 10 years ago. But if you ask their family, the family might say, oh my gosh, he did terribly with his pain control. So often our memories and perceptions are very different, and we can be very sympathetic on one day to another person's pain situation, or not sympathetic, and that can change whether or not we think that person's tough or not. Whereas pain is such a subjective event that it's really difficult to, I think, for me as a clinician, say one person's tough or one person's not tough.
No judgments.
I'm not willing to do that. Now, we do look at people's pain objectively and subjectively. There are objective measures of patients' pain, and those things are in the realm of signs, not symptoms. So the signs are heart rate, blood pressure, and behaviors. Is the person writhing, or are they sleeping?
Right.
So those are objective measures of pain. And those things are valid in acute pain. In chronic pain, the body is able to suppress those objective signs. So a chronic pain patient doesn't fall into that description. So once someone's been having pain for 6 months or more, those objective signs of pain can go away despite the person still having significant pain subjectively, as well as on testing of their their nociceptors, they'll be having pain signals that are abnormal. So, and those studies can be done in animals and can be attributed to humans as well.
So it seems like for you as an anesthesiologist and for your colleagues, the thing you have to meet people where they're at.
Right.
And address their
exactly.
issues at the time in the appropriate way for them.
Right, and we take every person on a case-by-case basis. Every procedure they have done, it could be different than the last one that they had done, and they can bring to the table a whole host of new factors. As people get older, they tend to handle pain better. They can cope better. Sometimes there's some schools of thought that think it's just because the nerves are slower. They don't transmit the pain signals as well. But I think it's also psychological. They've experienced more and they know how to psychologically handle and deal with that pain better than they did when they were 18.
Sure.
And that's analogous to the rest of their lives probably as well. So with pain, it's the same thing. And then there's psychological factors, stressors. Are they going through the sale of a house or a divorce or a loss of a job? Any type of additional anxiety reduces the coping mechanisms for managing pain well, just like it would reduce your ability to cope with any problem in life. It's much harder to deal with a parking ticket if you're also trying to close on a house at the end of the day.
Right. When life is good, everything is easier.
Right.
When life is tough, everything's harder.
Yeah.
Well, I do want to talk a little bit about the different techniques that you have available to you to use.
So currently in the anesthesia community in this country and throughout the developed world, there's a large focus on multimodal analgesia. And to talk about that, I'll just say that if we talk about pain relief or analgesia, there are two main categories. One is opioid and one is non-opioid. Opioids, morphine-like drugs. So Percocet, Vicodin, and the rest, Darvocet, all of those medications that bind to opioid receptors and make people have less of a sensation of pain. Those opioid receptors, this is a bit of a simplification, but for the most part are in the central nervous system. There are peripheral opioid receptors as well. But for the conversation we're having, in the central nervous system, the opioids act in the spinal cord and in the brain to suppress pain signals and help people cope with them better in their emotional pain centers. Opioids, as everyone knows, have a whole host of negative side effects, from nausea and vomiting, itching and constipation, to other things that can be more acutely dangerous, oversedation, respiratory depression, and death. So opioids are one tool and have been a great gift to the pain relief of human beings since opium was first used medicinally. However, there are a lot of side effects.
So there's a time and a place to use it.
Right, and to use that word multimodal, what we're trying to do is use opioids appropriately in a reasonable dose to minimize those side effects while using other modalities to supplement the opioids, replace the opioids, and possibly provide better pain relief than opioids can. Opioids don't provide great pain relief when we talk about issues like chronic pain development. Opioids are very bad at preventing the development of chronic pain, whereas some of these other modalities, non-opioid analgesic techniques, are much better at minimizing the risk of someone developing chronic pain or having poor pain control at some point during their acute pain phase. And that's called opioid-induced hyperalgesia. So the minute our bodies are exposed to an opioid, our endogenous opioid receptors become minimized. So maybe I could focus on the other modalities, because those are more interesting.
Yeah, we just have a few minutes left. Okay. So tell us what are the common things that you would use.
I think the most important one are the local anesthetics in numbing techniques. And that's a whole host of injections, from local infiltration of a surgical site by the surgeon to peripheral nerve blocks done by the anesthesiologist, continuous peripheral nerve blocks, again, local anesthetic near the nerve, similar to a dentist applying local anesthetic. In the dentist's office, those local anesthetics are only designed to last for a few hours.
Right.
Whereas in our techniques, we're trying to get them to last as long as is reasonable for that patient's recovery so that they can have the best numbing pain relief. And numbing pain relief is much better than opioid pain relief because the central nervous system never experiences the pain. The local anesthetic just blocks the nerves. It's called a nerve block. And it's similar to an epidural. An epidural is the same concept, local anesthetic next to nerves, except it's in the spinal column. So we have numerous techniques to do this, and over the last decade, anesthesiologists have maximized the utility of ultrasound technology so that we can apply those local anesthetics accurately and safely as often as possible. And it's really created a greater acceptance of local anesthetic techniques and block techniques by surgeons as well as by their patients. And it makes ultrasound techniques allow us to not just do it safely, but also more comfortably. So I could do a nerve block for a patient without giving them any sedation, and they wouldn't say that it was that uncomfortable. It'd be very well tolerated.
And it can be for a lengthy period of time.
It can be for acute pain. It's most important to keep someone numb for in the range of 48 hours to 5 days, depending on the procedure. Sometimes our nerve blocks only last a day if that's the right thing for that patient with their recovery and physical therapy, because unfortunately with the numbing techniques we do also see motor weakness temporarily until the nerve block wears off. So if it's a lower extremity surgery, the person can't walk otherwise, then that can limit their active engagement in physical therapy and can lead to some muscle weakness. So there are some limitations for sure. Other multimodal analgesic techniques include non-steroidal anti-inflammatory drugs that everyone's familiar with, antidepressant drugs like Cymbalta or Effexor, Lyrica and Neurontin are in the category of anticonvulsants.
Drugs that we really wouldn't think of
but
as
those are
pain
very
medication.
helpful, particularly when used preemptively and throughout that acute phase of pain post-surgically in the first 48 hours and can really maximize non-opioid analgesia and minimize the opioid-related side effects.
Well, this is great information, and it's I'm sure it's reassuring to people to know that, boy, best practices are now to stay on top of pain management and really keep people comfortable.
If I could summarize just briefly, just to say that I said earlier in the program that I didn't think nationally these techniques were employed as often as they could be. But I would like to say that the philosophy of our anesthesia group at the hospital, which is supported by our surgeons, is very progressive. And we really are using state-of-the-art ultrasound-guided techniques as well as other multimodal drugs to maximize a person's pain control and maximize their satisfaction with the pain control aspect of their surgery at our hospital.
Well, thank you so much for being here, Dr. Beck.
Thank you.
Good information.
Great questions. Thank you.
Thank you for joining us. I'm Jenny Dyke, and this is Aspen Valley Hospital's Medicine in the Mountains. I've been talking with Dr. Chris Beck, the Chief of Anesthesia Services out at the hospital. We'll see you next time. Bye-bye.